Hi, I'm Dr. Brian Kaufman here at ESH in Thessaloniki, Greece, enjoying a conference on B-cell lymphomas, particularly CLL, and I'm with my friend Dr. Cathy Wu. Dr. Wu, do you want to introduce yourself?
Sure. I'm Cathy Wu. I'm an investigator at Dana-Farber Cancer Institute, and my area of research is chronic lymphocytic leukemia.
So, I've heard your lecture a couple times with some different twists to it, and I'm very excited about you understanding about kind of the evolution of how a tumor evolves and tumor heterogeneity. Could you kind of explain to us what tumor heterogeneity is and a little bit about clonal evolution and genetics and epigenetics? You don't have to do it all, but give us a little bit of a sense of that, yeah.
Sure. So tumor heterogeneity is not a new concept. It's been around for a long time. And fundamentally, the basis is the idea that cancer, by virtue of the fact that at its very heart is a process where there's genomic instability and acquisition of mutations, that it has the ability to evolve over time. And that as the tumor acquires mutations, it can acquire it in a diverse way. So you might start with one population, but over time, different subpopulations will evolve so that the composition in total comes from one ancestral clone, and yet there is variation within that same population.
And are those called subclones? Or?
Subclones. So this idea was thought about even back in the 70s, and it was conceived that this would be the major challenge to therapy. And in fact, that's what we're seeing. What's happened in the last couple of years is that we've had ever better tools to actually measure, quantify, understand this. So, and what I'm talking about is the ability to do genome-wide sequencing at a feasible, scalable cost. This is next-generation sequencing,
right.
And that's really broken open our ability on a genome-wide level to look at mutations and measure them, quantify them, identify them. And what I would say is that, you know, the first level of understanding that we had with regard to the mutation landscape was yes, no, are these mutations present or not? But as we've gone on further, we've begun to realize that it's not so much yes, no, but how much. And so within one sample, where you're going to say there's, let's say, 10 mutations, some of those mutations are going to be present in all of the cells. Another mutation may be present in 30% of the cells. Another mutation may be present in 40% of the cells. And what does that mean in terms of which cells have one, both, or none of those mutations, maybe another mutation. So there is variation to the degree genetically that these mutations are present at clonal or the entire population, or subclonal, meaning within a subpopulation.
So let me take one step back from that, and a concept that I think is related but is happening at the single cell level, if I'm right, is the complex karyotype. Mm-hmm. Am I getting that right? So the complex karyotype would be the one that maybe had multiple mutations, exactly. But that would be a single cell that would, because I know that's a bad prognostic factor.
Right, so karyotyping, again, so the concept of heterogeneity has also been very much appreciated over the years, decades, because of cytogenetics and karyotyping. So when you look under the microscope and you see these individual cells, when we say complex karyotyping, it means that there are many different alterations and they're present in different constellations in different cells.
Okay.
So it's both.
Okay, so it's both the individual cell and the difference, if you saw all different kinds. So exactly. Some had 17p deletion, some had a 17p and an 11q, some just had the 11q, then you'd say, oh my goodness, yeah. we're looking at a lot of different things here.
Correct.
Okay, so it would seem to me that this would have tremendous implications in terms of how the disease progresses, both with and without treatment. Can you kind of, if there's subclones, some might be more favorable, some might be more favorable in response to a treatment, more refractory to that treatment. So walk us through what your research has shown us.
Yeah, so I'll preface this by saying that this is an area of active investigation. So I think we're at the point of, we have some really compelling concepts to go after, and there are many groups worldwide who are trying to understand this. So the research that my group has done has to take a next generation sequencing approach in 149 samples, and to characterize that heterogeneity. And in doing so, we found a couple really interesting things. So I think the first concept is the idea that if a mutation is clonal versus a mutation that's subclonal, already that gives you a sense that there may have been an order of mutations that are acquired earlier in the evolutionary history of that cancer versus mutations that are acquired later in time.
So the clonal would be earlier because it's across the entire clone, and subclonal would be like a grandchild of that that broke off and added a new mutation.
Exactly. So if you kind of think of a lineage tree,
okay,
right? So what was the ancestor, and what are all the progeny?
Okay.
And there can be many, many branches to that tree. And I think the interesting and appealing aspect of that sort of analysis is the idea that there is a stepwise progression of how these mutations are acquired over time in CLL. So I would say an active area of investigation is trying to understand what are those mutations that got a normal B cell on the path toward malignancy. What are things that were acquired early on? And if we understood that, how does that change behaviorally in terms of CLL, which is a disease where patients have quite high variability in whether or not they have very aggressive disease or a more indolent course. So is there something about the early steps that mutations required that kind of set one on an evolutionary trajectory? By the same token, what are those later events? What are those events that really push the disease to take on a more aggressive turn? Are there consistent mutations that drive that? So that's one area that I think is quite interesting. The other is the idea that there may be small subpopulations that predict future relapse. In other words, there may be bad actors within that population that when it's kind of masked within the population, they hang out, but they don't really cause too much problems. And yet in the setting of therapy, whether it's chemotherapy that kind of wipes everything out, but this little subpopulation is hanging in the wings and ready to take over, or whether there's strong selective pressure because we have new targeted agents that really push on hitting a specific pathway, and whether that small subpopulation is somehow resistant to that pathway and now is given full reign to kind of take over. I think that's another implication of the fact that you have many different small subclones within a population that really have the ability to adapt to whatever we throw at it therapeutically.
So I have a bunch of questions, but let me hold it there for a second and we'll pick it up in a minute.